You can intervene in terms of when people hit the health and care system, there's preventative action, but equally health status and health inequality is a mirror. It shows us, it tells us what the social, economic and environmental circumstances are that we have in our wider society. That is what we are seeing. We're seeing differences in wider economic, social and environmental circumstances.
Good afternoon, everyone. We're going to get started. I can't see how many we've got. I think it's around 40, which is fantastic. Thank you all for joining this afternoon. I'm Janet Budd. I'm Director of the NHS Transformation Unit, and I'll be chairing this afternoon's proceedings, which is the first of our inquiry sessions for this Health and Inequalities Commission. Levelling Up Commission. So hopefully everyone's seen the data pack that's been sent through, and really at the end of that pack there was commentary really of what we're looking to achieve. So as identified in that, we're looking to focus our attention today in this commission on health and social care within the Levelling Up agenda, and specifically looking at what solutions and recommendations we can take forward. So we're not looking to, I suppose, repeat some of the analysis or understanding of the problems, but really look for where we've got examples of great delivery and solutions that we've already know about and we can share. So as you'll note, actually, this session is actually being recorded. Hopefully that's okay with everyone, but that's so we can reflect back afterwards and make sure we've captured everyone's comments. We've got a fantastic audience today, a mix of local authorities, NHS trusts, ICBs, government as well. So thank you very much everyone for attending. And what we're planning to do, we've got 2 hours, slightly behind time so far, but we'll try and catch that up. We're going to split it into 2 sessions. The first half will focus on prevention and population health management and health inequalities, and we've got 3 panellists: Geoff Matsu, Chief Economist at CIPFA, Christina, Director of Communities and Health at Bristol City Council, and Abdul Razaq from Director of Public Health at Blackburn, and Darwen Council. So as I said, we'll focus our first hour, and each of those panellists will give us a brief summary, and then we'll go into some questions and discussion with the wider audience. And then the second half of the session will then focus on the integration of health and social care. And our panellists for this will be Geoff Little, former Chief Exec of Borough Council and place-based lead for the Borough's Health and Care Partnership, Richard Stubbs, Chair of the Yorkshire and Humber Academic Health Science Network, and Sarah Reid, the Senior Fellow at Nuffield Trust. So as I said, we'll have a brief statement from each of the panellists to kick us off, and then we'll open it up for questions and answers. We have got some pre-submitted questions I think people have sent in, so we will start with those unless we get something through on the chat to kick us off. So yeah, I think that's probably all from me, and we've got Shivani in the background from Curio, who will be helping us take notes and actions on the meeting. So please feel free to either raise your hand or put comments and questions in the chat as we run through. Yeah, your involvement is absolutely key to making sure we get the most out of this session. So thank you for that in advance. And so I'll pass over first of all, if I can, please, to Geoffrey Matsu, Chief Economist at CIPFA.
Thank you very much for allowing CIPFA to share some of our reflections on how we can improve sort of outcomes in public health and in social care across the UK. A lot of talk around this has been circulating for some years now, and with the spring budget to be announced in just a couple of days' time, these reflections are particularly germane, we feel. Of course, spending in public health services in England has been increasing over recent years, but of course that has been overcome by the increase in demand pressures that the sector has been facing. And so, and on top of that, the high rates of inflation that we've been challenged with over the past 2 years have made difficult circumstances that much more challenging. The good news is that there has been an increase of around 3% in terms of funding for public health services over the previous year. It's a small increase, but it's still relative to other public service areas. That increase is something to be appreciated, because many other areas of public services have actually received real-term cuts and even nominal cuts. Despite this, there is a need to focus more on prevention. A lot of the focus has been on meeting acute needs, and we find that there are very simple things that government can roll out in local communities that sometimes we take for granted. These things are easy to cut, particularly when government is disinclined to increase taxes or to cut public spending in any service area. We often find that the easy solution is cutting longer-term investment, and that is often where preventative care comes in. Having said that, a lot of the solutions to prevention don't have to cost a lot, and some of the things like health checks and screenings, particularly for cancer, requires a lot more funding. And just encouraging people that these health checks are available and that they should be used. In many areas, the health checks have actually been taken away. And so while the near-term cost savings is there, the longer-term outcome is that less long-term chronic diseases such as cancer are going to be detected. And so government does need to be mindful of that. Coming off of a few years of what feels like a few years now, and it has been, of the post-pandemic recovery, a lot of attention is around infectious diseases. And so looking to see how we might be able to create frameworks in place that funds this adequately so that the next time around, the impacts aren't as significant. In terms of things like simple things like continuing to help people cut smoking habits or alcohol-related addictions. These are things that through working with place-based strategies, so it's not just government dictating what should be happening, but working with community-based interventions, sharing data across different regions, that collaborative framework of working with local authorities, the NHS, and other partners, including the private sector, can, we feel, lead to much more effective prevention and public health services. And finally, I would just flag up that CIPFA has recently published the Integrating Care Policy Principles and Practices for Places. And this report sort of outlines the strategic place-based and preventative approach that has this longer-term focus on outcomes. And part of focusing on outcomes is that process of monitoring and evaluation. So we need to be much more rigorous in that aspect of how we provide public services. In the UK, I think we focus a lot on sort of the design of programs and interventions, plus how we're going to allocate funds, and then we somehow lose track of monitoring and evaluation. So if you're interested in learning a bit more about our thoughts, that report I'll put into the chat. But I'll stop there and return it to you, Janet. Thank you.
Thanks, Geoff. If we hear from all of the speakers first, the panelists, and then we'll come back to the questions and sort of a summary. So actually, if I can ask Catherine to come in, Christina to come in.
That's right. Thank you, Janet, and thank you, Geoff. Just want to start, Geoff, by slightly correcting. I wouldn't want anybody on this call to go away by thinking that the public health grant has been increased. It's decreased from 2012. Every year since 2012, there has been a decrease in the grant, and there was that very small uplift last year, which was completely offset by the Agenda for Change uplift. So I think anyone working in a local authority will be very familiar with this, but it just wouldn't want to sort of create a misconception if we're talking about the public health grant in England specifically. So I just wanted to start my sort of scene setting with stating some of the obvious. We talk a lot about health inequality and we talk a lot about prevention, and very often we're talking about different things. I think Geoff talked about the importance of being very mindful about evaluation and outcomes, and that means we need to be very forensic and understand what it is we are talking about and what it is we're trying to do. So inequality is essentially it's differences in access or outcomes or health status. Prevention is purposeful action to reduce, prevent, or stop negative effects. So when we put those two things together, we need to understand what it is we're trying to prevent, at which point in the system, and at which level we want to undertake the prevention. And I think Geoff gave some very good examples. You can intervene in terms of when people hit the health and care system, there's preventative action, but equally health status and health inequality is a mirror. It shows us, it tells us what the social, economic and environmental circumstances are that we have in our wider society. That is what we are seeing. We're seeing differences in wider economic, social and environmental circumstances. So as a Director of Public Health and Local Authority, along with my other colleagues, we would see our primary function as being to enable the systems within which we work, which include the ICS systems, but there are other systems, criminal justice systems, housing systems, economic systems, business systems, to encourage and enable those systems to create the conditions for health. And when we're thinking about prevention, therefore, I'm drawing a little sort of pyramid here, or it could be a circle. The creating the conditions, housing, employment, education, safety, primary prevention, ensuring that individuals and communities are well connected, that people know where to access support, that we're reducing isolation, that we have places to meet, and we have good social fabric. Primary prevention, which is things like thinking about making sure that we've got equal access to immunisation and vaccinations in our primary healthcare programmes. And there is in every area much more a variation in that than you might think. Certainly on my own patch, we've got very wide variation in terms of uptake of routine vaccination and screening programs. Our health visiting program, and I'll just put a plug in here, health visitors, now known as public health nurses, they are one of our only remaining universal health offers. So GPs, primary care and health visitors. And health visitors provide a targeted, a universal service, but it's also targeted to those most at need. And that locks into children's centres, family hubs, and so forth. Early intervention. Case finding, which population health management is enabling us to do, that is looking at clusters of activity, looking at risk factors, and being able to case find from primary care to enable individuals or clusters of individuals to get enhanced care or early prevention. But prevention doesn't stop there. Secondary and tertiary prevention are equally important and indeed impactful. So, for example, if we think about something like knee and hip operations enable individuals to live healthy lives. So if we think preventatively, not just about the surgery, not just about going in, getting the mobility back, but thinking of that as a preventative action, which enables people to live healthy lives, we can frame it in a different way. And finally, end of life care. Huge opportunities for prevention at end of life, not just ensuring that the individual whose life is ending has optimum care and a managed and dignified death, but that everybody around that experience has is supported. So the impact on families, a situation which is badly managed or is well managed actually keeps people well, enables people to grieve properly, prevents people becoming unwell or sick or stressed, and contributes to the whole. So that's just, I think we've got a number of questions which I'm ready for, but that's just a little taster of the framework which I'm going to bring to the discussion. Thank you.
Thank you, Christina. And if I can then move on to Abdul for your summary, please.
Thank you very much, Jenna, really, and a very good afternoon, everyone. I'm, like Christina, really, a local director of public health, and I work within an upper tier unitary authority, Blackburn with Darwen, with a resident population of 155,000 residents. Our GP registered population is just in excess of 185,000. We have a very diverse and very young population. Over a quarter of our population is actually aged under 16. So we have a very strong focus really on children and young people's outcomes. We also have our population in terms of diversity it's a predominantly Pakistani and Indian Muslim population, and it's about 35% according to the latest 21 census. As a local place, really, we are working really at different tiers, really, in terms of our population health management and also population health and public health approaches. We are working with the Integrated Care Board. I'm a participant member. I provide my input to the board with our population health team. I'm the Director of Population Health in terms of the key population health programs, and there is investment that goes in. For example, to give clear examples, we to actually supplement our NHS health check program around population health management around cardiovascular disease and hypertension and overall multimorbidity. We have an enhanced health program through our primary care colleagues, which will provide anything up to our allied health professionals and our healthcare practitioners to provide anything up to 60 minutes worth of contact time and to provide linkage with our wellbeing services. So I think really in terms of the offer, really that's really how integration is actually beginning to actually then work its way through in terms of the investments and the programs to actually make those available at place. Our places, we have directors of health and care integration, and they're actually based at upper tier local authority level. So we have 4 of these because our integrated care system spans a geography of about approximately 2 million population, and is Lancashire and South Cumbria, which goes into Furness and Westmoreland. In terms of the wider determinants of health, we've had the Marmot Health Commission for Lancashire with a series of recommendations. Directors of Public Health, together with the wider system, worked through those recommendations, and we've embedded those recommendations within our integrated care strategy, which is using the life cycle approach from start well all the way to live well and work well, kind of age well, and we've also got an element around dying well, really, in terms of our population too. Our health and wellbeing strategy is actually currently being refreshed, and we're refreshing our joint strategic needs assessment as a key vehicle and tool for joint commissioning arrangements. I think it's fair to say really that we are very ambitious within Blackburn and Darwen. We were highly impacted by the COVID pandemic as an area of enduring transmission. We have relatively old pre-Victorian housing, and housing is a key determinant of ours. We have other issues really, such as HMOs. We have and we are working through really in terms of our local plan. We have very ambitious plans over the next 20-25 years through our local plan, with £1 billion worth of investment into the borough, together with our surrounding areas, for economic development and regeneration of our towns and our communities. And clearly we were in receipt of £20 million worth of levelling up funds as part of the national commitments. I think it's fair to say, really, just in terms of my final summary, just to build up on what Christina has actually outlined, public health really is the art and science of actually doing the impossible, really, with the least resources possible. Thank you so much, and I'll hand over back to Janet.
Thanks very much, Abdul, and thanks to the three panellists. So I think we've heard there really setting the scene really in terms of health, the prevention piece really, and then the challenges in terms of the finances. I think exactly that last line there really, Abdul, really does give quite a stark view really as to where we're at. I think when we looked at the data on this as well, I think you mentioned as well, Abdul, that post-COVID, you were adversely impacted, and I think that's something that we've seen across the board. Certainly that data pack that we've circulated was only up until 2019, and that already demonstrated actually in the majority of cases we'd seen a worsening, and certainly for the non-London ICSs in terms of the scoring. So actually, what can we do? What's the real differences there? What can we understand actually from what preventative approaches can help address this? So I think that's really to my first question. I'm happy to lead on to that one, unless again I've put those questions that we've had submitted in advance, but actually happy to take the sort of steer from the attendees. If you don't think that quite hits the mark in terms of what you'd like to get out of this session, then please do either raise a question or put your hand up. But if I start with that one, as I said, health inequalities are widening certainly after the pandemic, but having looked at that data pack, we saw it was already on track even before COVID struck. So what's the role of prevention really in addressing this, and how can we ensure this is taken seriously as a key component of levelling up? Is the levelling up funding sufficient? What else could be done, and what else have we seen actually? If we have seen in the examples of those London boroughs, for example, where we have seen significant switch to or improvement on those inequalities, what is it that we can take from those examples? So happy to open that up either to the panelists. Christina, I think you said you'd done some preparation in responding to those questions, but equally if there's other comments from the audience, happy to take those. Do you want to kick us off, Christina? Would that be?
Thank you. Yes, I'd just done my homework, that was all.
Thank you.
So yes, an interesting question, and it was interesting looking through the data pack. I think one of the things that I wanted to just pull out is that when we look at different population groups, different sizes of populations, what we sometimes call the denominator, the base population, depending on the size of that, different things emerge. So when you shine the light in different ways, different things emerge. So when we look nationally or regionally, what we can see from the data is the widening regional inequalities. When we go in, as Abdul was just describing, or my job in my local area, it's to be very granular. And it's to understand the within system inequalities. And that's really important. It's both. And I think the levelling up agenda has been focused, I would say, on a national regional footprint. So it's essentially, quite rightly, looking to level up the north and the south, basically, with some little variation, but level up the north and the south, because when we look nationally and regionally, we can see those inequities. However, when we look, if we take, say, a big rural authority, many of the rural authorities, if you look at them as a whole, might seem to have few inequalities. Actually, when you look into the data, you will find clusters of quite extreme inequality and poverty and other issues. So it is actually the job of the Director of Public Health to know their people in place. So I think it's important for systems. I'm in a health and care system of 3 authorities. Abdul, I think you said 4 or 5. Some are bigger than that. So it's important for ICS systems to work with their places and to work with their local directors of public health and others who really understand that granularity. So and it shouldn't be a trade-off. It's not a trade-off of the regional, national inequalities versus the within smaller area inequalities. It really has to be both. And when we're talking about prevention, it has to be forensic, informed, and purposeful. It's not a loose thing. It's not, I think we'll do a bit more of that, or I think we'll do. You absolutely have to do the legwork on what inequality you are talking about, at which level in the system, and I've just described a few, then deciding what the intervention is, and as Geoff has said, then monitoring whether that is working and whether you might have unintended impacts or consequences. I think it's important when we're talking, or I certainly feel it's important when we're talking with colleagues who are, say, in the health system or in the care system. Those are busy jobs, absolutely on the front line. So any additionality that we put in, where we are asking them to work with us on inequality and prevention, needs to address the outcomes. It needs to make the outcomes better in that area, in that specialty. So it's not seeing prevention as something separate to or outside of the system, but building it into everybody's business. So your cardiovascular surgeon doesn't have to become an expert on housing. They have to understand what inequalities look like in their area of expertise and what they can do to prevent and reduce that. Thanks.
And if I just thanks, Christina. If I just come back on that, though, so what's actually has that changed over time, or has that always been the case, or is it that we need to give more focused at forensic informed at the right level approach? Is that what will make the difference, I suppose, or actually is it to some of the chat that I'm just trying to pick up on as we talk through? Is it the funding, or what is it in terms of preventative approaches, or that will really help unlock that and see the outcomes change?
Yeah, the integrated care systems are the new opportunity. That is what is being presented to us, that we can work together in this way at pace and scale. I think we do have to be more focused and forensic, and we have to recognise the whole. So the opportunity for the integrated care system is it opens up more secondary prevention and primary prevention, actually. And we in local authorities need to continue to work with the NHS and others as civic partners, corporate partners, on issues such as housing, employment, green spaces, etc. But we're talking about complex adaptive systems, and I don't think any of us are terribly good at that. We like to go back to sort of the rational planning mode. And actually, if we're going to shift this, we have got to work as systems within systems, as teams within teams.
Thanks, Christina. Any other comments, Abdul, Geoff?
I think just on the team of teams, really, Janet, if I may. I think definitely really, I think integration at place at neighbourhoods really is really important, really. So we've got primary care neighbourhoods really on networks, really, as they're actually known, really. And look, I think we need to democratise health as well, really, in terms of this is the health of the communities. The communities themselves clearly are a key stakeholder, really. So co-production with communities in terms of being an asset-based approach is really vital to actually creating some of the solutions, really, because the solutions actually lie within those communities themselves, really, and they are the greatest advocates, really, for their own well-being. Sometimes, really, it's really about maximising some of that, but also actually providing the right conditions, really, that Christina actually talked about in terms of what was actually, but ultimately at macro level, really, if we're looking at really what will actually kind of level up communities within our system, really, then I think anchor institutions, really, a word that we've not heard really during this session, is going to be vital, really, because each of our public sector organisations, really, and private sector businesses, really, are key anchor institutions actually providing health and well-being to our local residents in terms of actually providing employment, providing service, providing goods, really, and actually providing procurement opportunities, employment opportunities. So, for example, our East Lancashire Hospitals Trust and the NHS is actually recruiting through the armed forces, through the Veterans Network, in terms of their transition, really, from military service back into civics, as an example, really, within post that need filling, really, and provide value in terms of care for our local residents. So there's innovative work actually then happening, and I think really it's actually maximising and accelerating that, really, in terms of the levelling of agenda. But ultimately, from an economic perspective, really, one of the biggest issues that we face within Blackburn and the Northwest is economic inactivity and the productivity gap, really, between the health and the ill health of our residents. Thank you.
Thanks, Abdul. And actually, just in terms of reference there, and if I can just pick up on one of the comments from Hamish Dibley. So what does levelling up actually mean within the context of health and social care? And I think actually this is the point you're making, Abdul, that it's broader than just the health aspect. Clearly, there's a community response. And actually, just to make people aware, this is the first inquiry session, in case you weren't aware. There will be others inquiry sessions, both at place, but also for the different pillars of housing, crime and justice, and also for education. So I think we probably will explore that question probably across all of those inquiry sessions. Okay. If there's not any more comments, then I can move us on to the next question, conscious of time as we work through this. So while levelling up focuses on regional inequalities, and there's certainly high levels of deprivation in the north of England, as we've certainly seen from the data as well, how can we better address the levels of health inequalities within cities, boroughs and other localities? I mean, I don't know if our previous responses probably touched on this, certainly your comment there, Christina, in terms of actually let's break down the problem and really understand what that is at I suppose the more granular level detail of place and whether that's a rural community, etc. I don't know if there's anything more you want to add to that particular question.
Just that it is massively important to understand what denominator you're looking at this through, because you will, if you're asking different questions or shining the light in different ways, you will get different answers. And actually inequalities by definition can only be addressed at a very granular level, in my view. As Abdul was saying, you have to know your communities, their experience, what matters to them. We've not talked about the sort of risk and protective factors, which is, so we've got two levers here. One is we reduce exposure to risk, and two, we increase exposure to protective factors. And in order to do that, you've really got to understand the experiences of the communities that are impacted, and individuals and communities who experience sustained intergenerational inequalities have been exposed to many, many years of combined risk, the sort of thing that Abdul was talking about, poverty, discrimination, poor housing, racism, and all of that creates a stress response, which we're now learning, and we learned through COVID, or learned more through COVID, is actually intergenerational. So if you create risk conditions, people are living in risk conditions which continually put families under stress, there's a biological response, and that's what we see when we see inequality. I mean, if you step back from it and ask yourself the question, why is it that being poor should make you sick? Why should there be a relationship? Actually, it's because of those stress pathways, which are very, very profound. And so the levers we've got at different levels are to reduce the exposure to risk and increase the exposure to protective factors, which include being in control, autonomy, having a voice is a big protective factor.
And I would just add to that, I think those are excellent points that Christina makes. When we talk about data around health prevention, it's not just looking at that granular level of detail for health-related interventions, but also making sure that we have that level of granular understanding of what's happening in neighborhood services, within the school system, within even things like the criminal justice system. You know, how are these services being delivered at a local level? Because then they sort of cascade over time to health and have these detrimental health impacts. And so whilst we're on this, during this meeting, making this case that there needs to be more preventative investment, we still have no clear picture of how much public services currently spend on preventative actions, particularly at whether it's a local level or at, you know, a level between a council and what's happening nationally. And so sifting through that data will obviously require identifying which of the metrics are most linked together making sure that we're linking health with non-health measures. And I think this is something that it's easier said than done, because there's many, many types of indicators that we could be using. They're not just economic or health related, but there's social and cultural factors as well. And the one final point I would want to make around this is to understand what's happening across these regional tiers. We also, I think, need to make sure that to improve the outcomes, we need to improve the incentives to invest in prevention across each of these layers. If the various organizations and entities at each of these levels don't have an incentive to really be helping each other or coordinating their actions and behaviors, then it's going to be very difficult to say, okay, well, holistically, we're aiming for these types of macro outcomes, when in fact, at a micro level, there aren't incentives to actually reach those targets. And so A, we need more data, but B, we need to make sure that when we have the data, we then use it in a way that creates a framework for incentives to allow these regions to work better together. Thank you.
Thanks, Geoff. And just interested, actually, because there's a question in the chat as well about actually, sorry, let me just scroll back up. The flow of funding, I think we've had a few different ones now. Let me just find it again. But to your point, actually, even if we got that data, and if that's one of our recommendations in terms of getting some more of that data, actually, would that change how we prioritise where the funding goes to potentially? Or, you know, what are some of the things that we might need to unlock to help facilitate that? So I think we said, I'm sorry, I've lost the who put the chat in there. I'll have to come back to it, but it's that question of it, will that help actually? The levelling up requires disproportionate investment to ensure the same assets are available. So how do we shift the funding to those areas most in need? Yeah, your thoughts on that, please, Geoff. And actually, would that data help us be able to identify more in terms of those areas of need?
I think it does help, but the difficulty is that a lot of this data is backward looking and preventative investment is forward looking. So we need to make sure that we're investing in the right places that are going to then lead to impact at whatever X number of years going forward. We definitely should be targeting more investment in areas where outcomes are poor. That's sort of a non-starter. But as I said, if we can identify areas where it's not just income or wealth metrics, but it's things like schooling or rates of incarceration that then have a pattern of leading to the need for utilization of health or social care services, then it's in those areas that we should be directing more investment. But it really does require looking forward at, okay, this is what we're trying to achieve, but the data that we have sort of looks back a few years and trying to bridge the two, if that makes any sense. Okay, thank you. And I think that actually links, I suppose, from a preventative approach perspective into the next question, actually. So how can healthier choices be made for most deprived areas to try and level that playing field? So aside from the funding side, what else could we do in terms of the choices made to try and level that playing field?
Yeah, I thought it was an interesting question.
Yeah.
So my position, and I should be interested to see where Abdul lands on this one, is that individual behaviours, including choices, are actually constrained and defined and enabled by those wider social, economic and environmental conditions. And that is, I think, quite a general public health starting point. And that's important, because if you don't take that position, if you take a position that individuals can make, everybody's equal and everybody can make healthy choices equally, it becomes individual responsibility. And generally speaking, a public health approach is about populations, and it is understanding that none of us are that free, actually. We are all constrained. The choices we make are absolutely constrained. So if I give you, I was trying to think of some practical examples. So I've got some, forgive me, they're from Bristol, but I thought they sort of hit the spot here. So for example, we have disinvested in traditional weight management services. Now, local authority, we do what's called tier 1 and 2, so not the services that you've been hearing about that give people the sort of drugs or do tummy tucks. That's the NHS. What we do are more sort of behavioural interventions. So we like everyone else, have got a growing weight problem. We don't use the word obesity because I think it's a very medical term. It doesn't help. It's quite blaming. So we talk about healthy weight, and healthy weight is made up of the right levels of physical activity, the right intake of food, and the right mental health and the right environment. All of those things together, and we're working along with a number of other authorities with a program called Busy Bodies. Now, Busy Bodies works deep within communities to understand what is important for them. And the result of that is we've got one amazing program designed by and with and for men called Gutless. And that is a men's healthy weight group. And they are approaching the issue in a way that's right for them. And we've got other groups. Another example is working with our Somali community. So a Somali women's group got very concerned about the number of fast food outlets on a particular road near them. Now, we could have done this. We've done the mapping, but from inside the organisation, we wouldn't have had the moral weight to sway trading standards or to make the change. Our Somali women's group did, working with us, working with trading standards, going into those outlets. And actually, we had quite a change. That was a change in the environment. So there's just a couple of small examples about an approach to healthy choices, which isn't about how do individuals make healthy choices, but it's about how do we create the conditions. I'm sure Abdul will have other examples.
Thanks, Christina. Great examples. Sorry, can I just check though? Did you say you disinvested in those, or were they?
We disinvested in traditional weight managers. So a lot of authorities had invested things like Weight Watchers. Now the number, it's not that weight, but the number of people going through and the outcomes weren't even going to touch the sides of the shift in unhealthy weight that we were seeing at population level. So we had to do something quite different. We were constrained by the money, but we turned that into sort of just a different way of doing things.
Brilliant. So you are funding these different examples that you shared, for example.
So the busy bodies is what we are now funding. Fantastic. Rather than the traditional services.
Thank you. That's helpful to clarify. Thanks. Abdul, did you want to come in on that as well?
Yes, I do. Really. Thank you. Thanks, Christina. I think I'm fully on side really with Christina's summary really around the actual debate really about individualization. How much of a healthy choice is actually a real choice, really, that can be made by those individuals, really, and not everyone has the same income level, the same literacy levels, the same digital literacy opportunities, really. So a lot of this really is really about, access barriers, fundamental kind of other barriers, really, which actually exist in terms of that leveling of agenda, really, in terms of, basically, so we need to get to adult learning. So we're doing a lot of work really around, for example, in what we're call multiply, which is all about numeracy. So we have, basically to make sure really that our population can actually understand how they can actually understand numbers, how they can actually, kind of budget, how they can actually do a whole range of kind of daily activities really through numbers, and that's the multiply type program in terms of that process. I think there are so many barriers really in terms of the equality of opportunity. So therefore, where do we need to actually focus and prioritize? But ultimately, communities themselves really have shown great resilience and mobilization themselves, really, out with statutory organisations. Businesses have actually stepped up really as well in terms of their responsibilities, in terms of social responsibilities, and they actually plough in a huge amount of resource really up and down the country in terms of social value, and in terms of enabling communities to empower themselves. And I think celebration really, we have an organisation within Blackburn and Darwen called One Voice. One Voice is all about social cohesion. And it's very much about communities coming together, really. And we celebrate, and we have annual awards, and we actually celebrate really a whole range of things, really, in terms of celebrating diversity, inclusion, culture, and well-being overall, really. So we have a health and well-being and a leadership award, really, which is predominantly young people. But the young people are our future, really, and I think ultimately we need to make sure, really, that we are providing aspirational opportunities when the macroeconomic context and the national economy is not at its best. So therefore, I think we need to give hope, and aspiration is really important, really. And I think the art of public health really is also to actually provide those two things, really, when the horizon is not looking as rosy as we would want it to be. In terms of the actual resources, really, they're clearly money and investment is always being talked about, but transport links, simple things, really, where rurality, I want to raise the issue around, we talk about, cities, and we talk about towns, and we talk about other things, really, but I've worked on at least 2 areas now within Lancashire and in Suffolk County, really, where rurality and transport have been the major drivers, really, of inequalities, really. There's only one road into a particular hamlet or village and another one out, really. So what opportunities are there for residents who face transport barriers and economic kind of issues? The other kind of aspect, really, is we do have something called a Health Equity Alliance, which we've actually set up, and that's looking at how do we tackle all of these issues and keep that narrative going together, really, from those Marmot recommendations, really, around social determinants of health and well-being. But ultimately, it is very much about bringing our resources to bear, but shifting, but the prevention shift, really, in terms of burden from treatment to prevention, clearly needs to happen, really, at scale. And I think, really, that really is one of our significant challenges. And I think we're going to have to look at, as to whether we can do that, really, through our anchor institutions, or whether we require additional pots of funding, really. And it probably requires the actual strategy to, it probably requires, as it did, really, in terms of levelling up, really, for West Germany and East Germany, we need a different scale of investment nationally around levelling up to actually truly get into this agenda for the next generation. Thank you.
Thanks, Abdul. You picked on so many points there. I think if I can, I think we'll try and open this up now. But there was a particular point in there that you said, actually, that in terms of the social cohesion, it's not just really for public health to be driving this agenda. And I think that's probably something that was picked up from, again, another comment from Hamish Dibley. If we accept that public health inequalities are getting worse, not better, does this mean we need to recognise the limits of standardised public service provision and that necessity, I suppose, to broaden out within our communities? But I think the point you're trying to raise here, Hamish, and feel free to come in and say this directly if you like, namely, we need to move from a focus on equity over equality and designing services against needs. So I don't know, Hamish, if you want to just expand on that a bit more.
Yeah, no, thank you, Janet. It's just been kind of my personal professional experience that over many years, approaching decades now, that in local public services, we tend to have a one-size-fits-all way of delivering service provision. We talk the language of standardisation. In the NHS, we talk the language of pathways, etc. But if we recognise we've got a real challenge with worsening public health inequality, it's going in the wrong direction, not the right direction. And I think that's beyond, I would hope, dispute. I just wanted to have a conversation with colleagues about, well, actually, should we not be talking more about equity, about actually delivering services that are almost bespoke by default? So we're customizing the care, we're customizing the delivery of services that's tailored and targeted around cohorts of individuals' needs, rather than doing what I see, which is we may talk about the need to cohort people, but we actually deliver public services very much in a very regimented, standardized, one-size-fits-all way of thinking, when that flies in the face of what people like Geoff was talking about earlier in terms of what the data is telling us, and Christina and Abdul.
Thanks, Hamish. I don't know, Christina, do you have some initial thoughts on that?
Yeah, yeah, absolutely, Hamish. And I think, I guess, what I hear Abdul saying, and I think you'd hear most local authority, DPH, and social care leaders describing is that, exactly that. And I think the opportunities to have that tailored diversification is at a very micro level. So we've certainly got localities, which is how services are organising. So in City of Bristol, we're at about 500,000. We've got 3 localities, and services are organising around those localities. So a much smaller sort of domain of organising. And then our job is to make sure that the communities are engaged and leading and doing the sort of true co-production. So I think there absolutely are opportunities in this, and actually communities will come up with solutions. And I know, again, Blackburn and Darwen had the same, and other authorities, that when we had to roll out the COVID vaccine, and we had a number of our challenged communities, most vaccine resistant, it was the faith groups, it was the communities, it was our BME professionals who absolutely led the charge and brought the communities in, opened up all the mosques, the gurdwaras, the community centres, got people through, built community champions, and then we got our NHS colleagues to come in and do the jabbing. But it was, that would not have happened. It wasn't led by the NHS. It wasn't led by us. It was led by the communities working with us and them coming up with a solution that would work for them. So I think we've got lots of examples of how to make it work.
And could I just add that I think that idea of moving away from sort of a framework of equality to equity could be advanced by having more engagement with local government, because they do play quite a critical role in the health and well-being of their local populations. And coming back to that question around, how do we make healthier or allow for healthier choices? Well, I think some of the things that aren't even health care related are things like making sure that there's the provision of adequate childcare so that parents can actually be home to cook healthy meals and to provide, or encourage exercise for their children, for themselves. It's very difficult for household in a very deprived area, if you had a single parent working multiple jobs, then expecting them to cook a healthy meal and then go and exercise at the leisure center. Some of these things aren't feasible expectations for society to have of these types of households that we have today. And so those types of provision for more or better childcare, or for some people just having childcare at all, because I think many, as you go down that incomes level tiers, the poorer you are, the more out of reach things like childcare is. We know that childcare is very expensive in the UK, and so I think we need to link up these different domains so that we can make sure that there is resilience. And I think that's a key word, making sure that we strengthen financial and social resilience so that there are more opportunities for choices, because that bandwidth varies significantly depending on where along the spectrum of deprivation you happen to reside in. Thank you.
Thanks, Geoff. Completely agree, and hopefully that will come out as we move across those different inquiry sessions as well. I'm conscious there's probably been a few comments in there, and I haven't got all of them. In the last, if there's a final question that we'd want to take from the floor, I'm happy to take that now. You might just need to help me though, because I'm struggling with familiarity on Zoom to know if someone's just put their hand up or not. I don't know if anyone who's raised a question in the chat would like to raise it verbally, or if there's any particular final questions you'd want to be asking. How can ICBs create a health ecosystem that is predictive and proactive rather than reactive? I don't think we've necessarily touched on that yet. I don't know if there's any final thoughts on that, either Christina, Abdul, or Geoff, or from the floor.
Janet, if I may, really, I think there are good examples really where the northeast of England, for example, the ICB has actually invested in tobacco control. and basically put NHS monies alongside local authority monies in terms of, you know, basically the smoking prevalence really, and making smoking history. It's actually getting down to 5% really within a generation. So by 2030, ideally. So therefore, there are examples really where our NHS partners are actually being innovative with local government around both tobacco and alcohol. So the North East and Yorkshire and Humber really regions in particular really are doing some great work in that regard. Not to say there are other examples around the country, there are, but that springs to mind really in terms of a more preventative focused issue. The major challenges clearly at the moment for most integrated care systems really is financial balance and clearly the current challenges. However, I think there's great opportunity for the NHS as a key anchor institution through the integrated care approach that you do want and share, but ultimately to get to localization on place and neighbourhoods in terms of place-based working, but ultimately to do things really at scale that need to be done at scale in terms of subsidiarity, and to actually then have, you know, the population, the relevant population health programs really that we've talked about really, and actually make the best use of our resource collectively with statutory partners. Thank you.
Thank you. I'm very conscious actually that we've obviously, you know, interaction in the limited time that we've got is quite difficult. So as we said really at the start, you know, if there are examples that you've seen and been part of in your local you know, geographies, then please do share them. I think if you can just put on the chat, Shivani, the courier email that you could send those examples through to, and anything that we've talked about, again, similar to that example there, Abdul, it'd be fantastic to see more details of that we can actually include in the response back. Okay, so if there's nothing further, we'll take some of the chat and look to respond back on that as well when we've had more chance to digest some of the questions you've asked. But if I can move us on now to the second half of the session and say thank you to our three panellists that have helped on that first half, Abdul, Christina and Geoff, thank you very much. But if we move on now to the second half, feel free to stay obviously with us. We will focus on the integration, and really that last question probably helps move us into that space. So we have Geoff Little, Richard Stubbs and Sarah Reed. Geoff, if I can ask you just to open up, if I can, please, it's a couple of minutes, 3 to 5 minutes of your views really on the focus on integration to change the agenda in terms of levelling up.
Yeah, I wanted to start actually with something that Christina Gray from Bristol mentioned about stress factors across generations in deprived communities leading to poor health outcomes, and the lack of power within those communities having a direct impact on those outcomes. And when you think about the two big events in this country's history over the last 5 years, I think there is something to reflect on in terms of how we go forward with health and care as part of levelling up. The first option is Brexit, and I think personally that did demonstrate that people in communities living with the most extreme inequalities feel as if the existing systems have not changed their life opportunities. They feel a lack of control over their own futures, and there is clear evidence that that level of powerlessness does lead to poor health. And secondly, in terms of events over the last 5 years, that's been mentioned several times already, of course, is COVID, which clearly laid bare, as if it were needed, yet again, that places with the deepest inequalities had the worst impacts from that pandemic compared to the average. And across the north where I work, we saw in particular communities where you had an overlap of deprivation and concentrated Black and Asian communities. They suffered really badly. So we know that we have to focus on place and people if this is going to change going forwards. So thinking about solutions, as I say, all of that leads me to conclude that we have to include people living with inequality, give them a space for voice. We need to stop telling people in the most deprived communities how they should behave and work with them to help us change ourselves, our public sector systems and our public services. And secondly, the solutions need to be focused not only on engaging and empowering people, but be focused on the places where that inequality exists. And in our local places, we all know, we see it in our own eyes, history is there, where those places are. Nationally, I think that we should be encouraging the current and future governments, because this will take time, to focus on deep-seated reforms to those public service systems outside of hospitals in the healthcare system. There's so much to do within hospitals in terms of getting the waiting lists down, the access to emergency care to what it should be, and we all have our part to play in that. But if we're serious about levelling up, we need adult social care to be properly reformed. We need primary care reform. We need reform of mental health. We need prevention to happen as a matter of course, and at a scale where you see a shift in the balance over time of resource allocation from acute to community and preventative parts of the system. And that will not happen by wishing it. We have to find practical ways of enabling that resource shift to happen. If there's a ray of hope for me, the Greater Manchester system, where I've worked for many years until I retired a couple of weeks ago, commissioned a study by the University of Manchester to measure the impact of health and care devolution on population health. And the findings show that when you factor out all of the variables, population health in Greater Manchester, outside of London, but compared to the rest of England, population health fared better during those years. There are interesting questions within that research about, within Greater Manchester, there is not an equal improvement in relative population health. And that raises very interesting questions about causality. But there is, I think, there a hope that shows that empowering local places through integrated care systems can have an impact. But reducing inequalities experienced by people in the most deprived communities, in the end, it requires better jobs, high quality, stable jobs with good wages. And poor health is one of the two biggest barriers to people getting those jobs, the other being education and skills. So health improvement, as opposed to health services, health improvement is in the middle of levelling up alongside action to drive the economic growth that will create the good jobs and the physical regeneration to create places with all-round quality of life and well-being. It is about place. Integrating health and care services can make a significant contribution. But what needs to be done, most of all, is work at a place level or the place-based agenda. The big advances will come, I believe, if we take the opportunity of integrated care systems, those three-way partnerships at place level between the NHS locally, councils as leaders of place, and local people and communities themselves. So I'll leave it there because I've got more to say about the first question that was circulated in advance about the effectiveness of integrated care systems. So I'll leave it there.
Thank you. We'll come back then, Geoff, and so if we just need to wait and see if they deliver as promised. I'm sure you'll expand on that as part of that first question. If I move on to Richard, if you'd like to give your summary, please, in terms of integration to deliver improved outcomes.
Afternoon all, lovely to be here. So my name is Richard Stubbs. Just a brief introduction, I'm Chief Executive of an organisation called the Yorkshire and Humber Academic Health Science Network, or AHSN, effectively the innovation arm of the NHS. So we spend most of our time working to use innovation in all its forms to transform the way that we can deliver care for our patients. But also, while doing that, also having a very keen interest on local economic growth. And as well as being a chief exec of a local AHSN, I'm also the vice chair of the national AHSN network, which is a group of 15 AHSNs working together across England to shift the needle on hopefully some of the NHS's priority areas. I'm also, and this is probably more pertinent to the questions, I'm also a chair of a local enterprise partnership here in South Yorkshire. So I've been a member of a LEP board for a number of years. Recently became the chair here in South Yorkshire, working very closely with my Metro Mayor, Oliver Coppard. That also then makes me a board member of an organisation called the MP11, the Northern Powerhouse 11, which is 11 LEP chairs working across the north of England together. And also I'm a member of the Northern Health Science Alliance board. All of which, the only reason I mention that is because that's all kind of, I suppose, part of my own personal journey towards this question. It's one that I work on quite a lot during my day job. And I think my own personal journey has been one where I recognise, particularly through the local enterprise partnership, working with the Mayoral Combined Authority, that when I stumbled into the LEP many, many years ago now, my discovery was that as somebody who's been in the NHS for decades, it was a discovery of all sorts of different rooms in place that through a NHS lens were starting to tackle the kind of challenges the NHS was also grappling with. And yet looking around the room, especially in the local enterprise partnership, which is private sector led, I couldn't see a health person in the room influencing the spend of that money. And I think that quite embarrassing realization for me, I think, is what led me to a number of different pieces of work, both with my LEP hat on, but also my HSN hat on, culminating in this sense of a campaign, I guess, called Levelling Up Yorkshire and Humber. And that's an ongoing piece of work. We've delivered a number of reports and conferences and webinars on this. But really, I suppose it's my own personal vehicle with key partners such as the NHS Confederation and Yorkshire universities to try and bring health, I would say, more into the other rooms in place where key investment decisions are being made on transport, education and skills, housing, etc., without health nominally being in that room to influence how that money is being spent. We believe, through our work, as I'm sure many people have said already today, that health and wealth, good jobs, good health are intrinsically linked. But also, I'm very keen to make sure that when we're talking about levelling up, particularly from the north of England, unashamedly, I'm carrying a levelling up for the north hat on today, that we talk about it being an offer, not an ask of government. And what I mean by that is that the economic power that is dormant within the north is absolutely should be of huge interest to UK PLC. If you look simply at my own patch in Yorkshire and Humber, we have more health and life sciences companies, for example, than in Oxford and Cambridge combined. What they don't have is the investment rocket fuel in order to produce a sizable cluster that will start to benefit UK PLC. If you look at some of the work of my colleagues in the Northern Health Science Alliance and some of their seminal reports around the productivity gap between the North and South and how much ill health plays into that productivity gap per head of population, you can start to see the effect of good health on good jobs. Put it simply, if we leveled up health across the north, that's an extra £13 billion of GVA that we add to UK PLC's coffers. So we absolutely should be framing levelling up as an offer, not an ask to government. Within the recommendations of our first report on levelling up Yorkshire and Humber, I won't read all the recommendations, but certainly we were advocating for a much greater increase in health research and development spending in the north of England, as opposed to the Golden Triangle. A greater priority to well-being in all public sector investment decisions. We called for health to be included as an outcome in all economic development policies. We also wanted anchor institutions to align with strategies to help deliver inclusive growth, as a number of colleagues have talked about in the first hour, and also stopping on anchors that they should collaborate on transformational change in areas that are not within their core domain, which I think is what brings us onto the integration agenda. And how do we start to really move radically away from the siloing of our public service focus? I suppose my provocation, just to take us more towards the questions to come, is that the health and care axis, when talking about integration, for me, that's only the start of a real radical shift to what genuine place-based collaboration means. Sitting as a chair of a private sector-led local enterprise partnership, it's very, very clear that private sector business has a huge role to play in terms of preventative health and the role of employee-led wellbeing services, the role of getting our local businesses to understand the bottom line business case for themselves in terms of what a healthy workforce does to their productivity agenda, I think is absolutely key. So I think when we're talking about integration, let's not just limit ourselves to how we can get better integration at the health and care axis, but let's think about genuine, total public sector, total private sector, place-based collaboration, where the health of our local population is at the core of all of our efforts.
Fantastic, thank you, Richard. And actually, I'm just going to come in on that point because actually, I think as a commission, then I also flagged that as an identification of the different pillars, we needed private sector probably also in this conversation, so that it's not actually the 4 pillars of public service that can make the real difference here. So thank you for that. Very interesting. So if I move on to our final panelist, though, Sarah Reid, if you can give your summary, that'd be fantastic, and then we'll come on to the questions.
Sure, thank you, and thank you for having me. And just for those who might be less familiar, Nuffield Trust is a health and social care think tank based in the UK. We focus on different ways of improving quality of health and social care services. And yeah, so when we discuss this question of kind of where are the main opportunities for scaling integration, narrowing inequalities, and kind of making that cultural shift towards more collaborative working between health and social care, I really wanted to start off by just focusing on why perhaps integration hasn't been meeting its intended goals so far, and what we really can be learning from history so that this new round of reforms have their best chance at actually improving outcomes for patients and their communities. So I was just going to reflect a bit on, some of the reasons why I think integration policy hasn't worked as intended, but where there really are potential opportunities and solutions for doing things differently this time. So that first part, just looking at the evidence, what does it tell us about whether integration has worked? And at Nuffield Trust, we've been looking at kind of the 20+ year journey that each country of the UK has been on to better integrate services, which really has been a principle of major reform by each government since devolution across the UK. And I think it's really instructive actually to be looking at countries like Wales and Northern Ireland and Scotland, because they've more formally brought together health and social care organizations into single organizations or joint boards and partnership arrangements, and much a way that England is starting to, and look similar in lots of ways that ICS structures are looking. But despite this, I think we have found quite limited evidence that the policies in any of the UK countries have made a real fundamental difference to patients or how well services are indeed integrated. And, things like inequalities are still stark, of course, and widening in each place, which I think we've already heard some examples of and why that might be. And of course, while there are really positive local examples of where integration is working, which I know we'll be focusing on, when we do look at that national data that's available to kind of measure integration success, we find that things like satisfaction with care and support among patients has been stable or falling in each country. Things like delayed transfers of care, so how well the system is able to move patients out of hospital, have deteriorated over time in many places. And things like age-adjusted rates of emergency admission, so how well we're able to have this proactive health and care system that keeps people well and out of hospital hasn't improved either. And certainly with inequalities, as touched on, that gap in healthy life expectancy has been stubborn and persistent in each country of the UK, between the poorest, most affluent parts of the country. So with that, I think, that over 20 years of reforms have really only translated into modest improvements for patients and service users, raises really important questions perhaps about what integrated care can realistically deliver when it comes to inequalities, how it's being implemented and at what scale, and why countries with such different, significant contextual differences in their approach appear to have similar results. So I just wanted to offer what 3 quick hypotheses about why that might be, that might get us to a place of thinking where there might be interesting and important solutions. And the first thing I think is just about having really realistic expectations about what integration is set out to do and what it can deliver. There's been a real consistent mismatch between the objectives of integration and what we think improving collaboration between health and social care and other service providers and public partners can achieve. And part of this is because integration hasn't been happening in a vacuum. It hasn't really reflected the broader context in which changes are happening. We've talked about that a bit already, but there's chronic power and resource imbalances between the NHS and other public services, and it's probably quite unrealistic to think that integration on its own is going to be able to shift more services away from hospital and support people to live healthier and independent lives in their community if there's indeed insufficient numbers of social care and community care staff to really support and build those new models of working. As already touched on, integration has not been happening alongside big investments to social care and public health. And in fact, across every country of the UK, that's one thing they have in common, is that there's severe pressures and instabilities as a result of ever declining funding in these areas. And until those services are stabilized, I think our expectations of what we can do on this agenda need to be tempered. And I think there's just also a lack of joined up policy around health in general that Christina and others have already touched on. But broadly speaking, we know that improving population health and improving inequalities is rooted in really complex problems that are heavily constrained by broader government policies that influence a person's ability to live an independent and healthy life. And I won't go into, if we've already talked about what, and it's well known what some of those spending cuts and issues are, but I think again, and we need to be realistic about what coordinating services and greater collaboration will be able to achieve in terms of turning the tide on the health gap while this broader context remains. I also think reforms haven't always been focused on the right thing. Often, and this is often said, and I think panel members will be familiar as those in the room, but when we talk about integration, we often are talking about recreating new governance structures and ways of bringing strategic planning and finances together, kind of those organizational changes in hopes that more joined up care will naturally follow. But integration is far more of a cultural change than an organizational one. And there's some real cultural differences between health and social care and other partners that haven't really been touched in any of the reforms very well. And simply having a new mandate to collaborate doesn't mean that localities and places will be able to effectively collaborate. Where we see really successful examples of this, some of those are among my co-panelists. A lot of that has depended on a real history and a maturity of relationships that have been given time and space to build up. And so while those examples do exist, I think they don't exist everywhere, and they need that time to grow and evolve. And the current context may make that really difficult, particularly in areas where we have these extreme funding pressures that can leave organizational leaders protective of very limited resource. I think we need to be realistic about the reality there and accept that this relational and cultural change is hard, and it takes time. And that leads me to my very last point, which is just that integration is not and has never been a real quick fix to a problem of some of the ones we're talking about. We need those changes and new ways of working to be able to embed and take place over a long period of history. And I think despite integration being such a focus for over 20 years, it's really not clear from any of the evidence whether these partnerships have ever been given that time to properly embed and achieve the impact before they've been disbanded and replaced with something else that's similar but different. And one thing we hear a lot from stakeholders is this concept of integration fatigue, of people feeling like integration is disconnected from their day jobs, and that what they see happening is changing of organizational charts and governance arrangements, but not having that kind of feel embedded in their day job or what they're going to be doing differently with people they work with on a Monday morning. And I think until that bit changes, we might fall victim to the same mistakes and errors of the past. So happy to elaborate on any of those points in the discussion, kind of those practical solutions, but just wanted to set that context at the beginning.
Fantastic, thank you very much. And three very different summaries there. Obviously there's a theme throughout them all, but yeah, I think if you can try and remember just back to some of those updates from yourself, Geoff, in terms of the reform and the shift of resource, and Richard, sort of the wider health and care access, it's only the start, and what else we need to bring into that conversation. And actually, I think, Sarah, some of the things you've raised there in terms of some of the looking back points actually absolutely help us inform what we'd look to do differently. So, and relationships, clearly, we've not talked about those necessarily, but absolutely being key to the success of those changes being implemented and the time clearly that's being given to them. I'm conscious there's a few people in the chat that have been very good at putting regular questions in. Please feel free to put your hand up and raise those questions directly. It'd be good to get you involved in the discussion. And whilst you're just thinking about that, I'll go to the first question, if I may, and look for responses back from the panel. So, to what extent is the integrated care system approach suitably robust for all those different reasons, Sarah probably as well, for dealing with inequalities within each area? If the panel thinks it's not, how can the approach be strengthened? And Geoff, I think if I bring you in first, actually, because I think you said you had some thoughts that you could expand on in your initial opening summary.
Yeah, ICS is a few, but they were informed by experiments in different parts of the country, including Greater Manchester. So there is learning and some evidence, I think, to instruct us on how they can be as strong as possible going forwards to give them the best opportunity to impact on inequality, as well as the quality of services experienced by the public. And I believe they can do. My first suggestion would be that we push for further delegation of powers and resources within the NHS, but also across Whitehall to ICSs, and that delegation isn't just to the ICS, but from there to local authority level partnerships, and then in turn from there to the private neighbourhoods themselves. We need double and triple delegation. And that delegation needs a solid platform upon which it can rest. And that platform is two-way accountability. One way to the NHS England, Government and Parliament for NHS resources and performance, the other way to local democracy, both in tandem. And we've seen that that can work. The precise arrangements do not need to be uniform. Differential devolution or delegation is perfectly possible. I would suggest in principles, though, at neighbourhood level, we need structures and relationships with carers, friends, families, neighbours, self-help groups, community organisers. As I said before, we need to work with those experiencing inequality to help them change our services and our systems. At local authority level, we need political, clinical and NHS provider leadership working with the voluntary community sector. And at ICS level, we need the ICS to operate as one system with its localities and neighbourhoods, not as a two-tier hierarchy. And once we have that governance right, you have a framework then within which we can, for each ICS in its own way, develop its own programmes for real and substantial change. Programmes working with and benefiting people in the neighbourhoods with the highest levels of inequality. There are great examples, I think, in all kinds of places from which we can now build to the sort of scale and ambition we now need. Some of the experiences I've had and some of the mechanisms I've used would include strategic remuneration frameworks, which set out a 10 to 15-year vision and interventions combining economic, physical, social and environmental change for a place. Also, people and community plans, enabling community activists, community groups, self-help groups to shape, change and build relationships. And thirdly, provide a collaborative, small but full-time joint teams from the NHS and the council, voluntary community organisations, which innovate and then sustain and grow integrated service delivery on the ground. And I think what was said before by Hamish about not taking a one-size-fits-all approach, having bespoke packages of services for individual people and their families is entirely possible if you have those provider collaboratives at neighbourhood level. So we were asked to think about how government would help with all of this. And better what you might want to have said before by Richard about this being an offer and an ask, not just an ask. I think we should step back and ask what ICSs can do to help government achieve its objectives, and then make the case for further delegation to ICSs, and the case that delegation is good for the government as well as ICSs. So yes, achieving NHS targets in emergency and elective care, but also, for example, labour market productivity, preventing people with long-term conditions leaving the labour market, and yes, levelling up. And on that basis, I think there should be shared outcome frameworks for each ICS, not just with NHS England, but across Whitehall, picking up proposals in the white paper last February. And then government needs to create the space for local innovation and programme delivery. Much of this will be covered, I hope, by the Hewitt Review, but we do need rolling 3-year budgets for ICSs and local government in tandem, getting away from the short-termism. ICSs should be given the freedom to allocate those budgets in line with their local priorities and programmes. That, of course, has to be coupled with the challenge for each organisation within the partnership to demonstrate its own value for money. We need less ring-fencing, less short-term stop-start funding. And most of all, and I'll finish on this, government needs to help by top-slicing budgets across Whitehall to provide funding for pump-priming prototype programmes at ICS level. And they need to support us at ICS level to overcome the barriers of scaling from prototypes to mainstream systemic change. Barriers such as the time lag between investment in early intervention and prevention and the impact of that on cashable savings from reduced demand, hence the need for rolling 3-year budgets. And the barrier that financial benefits fall often to the organisations other than those invested in the change in the first place, which is why I believe we need a new approach to pooled budgets, encompassing the whole of the NHS, primary care included, and wider public services beyond the NHS and local government, integrated at that neighbourhood level. I believe, therefore, that the greater delegation of power and resources is not an end in itself. It is a way of enabling services to be joined up at neighbourhood level, to reduce inequality, but also to reduce the need for acute, expensive services. And therefore, given time and the right approaches, this will work financially as well as in terms of improving lives and services.
Thank you, Geoff. That was a very detailed response and well prepared. So I think if I just summarise, and I might not get this right, so please feel free to correct me, but in terms of the question, actually, are they suitably robust for dealing with inequalities, then your response basically is yes, but we want more delegation, more with two-way accountability, and actually the indication really of a rolling 3-year budget to support that financial longer term view of being able to make those changes happen. So I'm sure that there was more in your answer clearly, but I'm interested to know actually, is the group, the attendees, is that supported? Do you think actually that's the right answer? I don't know, Richard or Sarah, whether there's views on that, or actually across the attendees.
Absolutely, I mean, absolutely, with Geoff, particularly the longer term lens, the 3-year rolling budgets, etc. I think the point I was going to make on this was that, as with a lot of things in the NHS, the answer is always it depends. Although I think Ben's put a very concise answer in, which I'm, in the chat, which I find myself nodding along to. I was going to make the point that, for me, the culture within a particular ICS is going to determine how it defines its approach to inequalities. And what I mean by that, and some of this was picked up on in the first hour on prevention, is that the NHS can absolutely stay in its lane and think about inequalities with regard to the delivery of healthcare services. And we've seen an awful lot of really good practice there. I think in Yorkshire, I would point to my colleagues at Caldwell and Huddersfield Hospital and how they've looked at waiting times and the elective backlog, but with a health inequalities lens, and made very operational decisions, but very much that kind of NHS day job decisions on how to tackle an elective backlog with inequalities at the heart of their compass. Brilliant work, absolutely fantastic work. But we know that obviously when it comes to health inequalities, the NHS can look to define itself as deliverers of healthcare provision, but will it also expand itself to think about that health inequalities prevention, wider systemic issue that we've been talking about for much of the first hour? And I do think that different ICSs, depending on their culture, depending on the immediate priorities, the budget constraints, etc., the leadership will start to tackle this agenda in different ways. So I guess my answer is it depends. We've got a mandate to focus on the issue. I think the creation of the ICS has been a great in terms of absolutely making sure that health inequalities is seen as a North Star of the reasons why ICSs exist. But that doesn't mean that the NHS is in control of all the levers to pull when it comes to how to actually start to reduce health inequalities in its own places. And therefore, and I think Sarah made this point very well, leadership and relationships and long-term relationships within place are going to be really key to how an ICS absolutely determines its approach. I'd mention 2 quick examples. In West Yorkshire, there's been some phenomenal work by the ICS at tackling loneliness. actually taking money from an urgent and emergency care budget to tackle neighbourhood cohesion and loneliness, because they know that's an upstream intervention which is going to have downstream impact on service need reduction. In South Yorkshire, there's a lot of work on what we call Working Win, which is around employment services and health services coming together to think about how they can get people back into the labour market, not only being better for our productivity, but also, of course, as we talked about earlier with the health wealth axis, better for health as well. So one of the issues I think that I'd like to see ICSs kind of stepping out of their lane on, and not just seeing it as a health issue, is things like about digital. So when I think about a transformation agenda, we know that services are being digitized at a rate of knots, and the pandemic has only helped to accelerate that. There's a huge potential for digital services to exacerbate health inequalities. In order for us to mitigate that, we need to think very carefully about how we deploy digital services, people's access to digital, access to broadband, access to data, confidential spaces, all those kind of things are absolutely crucial to make sure that digital is an enabler of health inequality reduction. That's not something the NHS should tackle alone. That's not something that health and care should tackle alone. Every single public service provider in a place has the same issue around digital access and therefore people's accessibility to its own services. So for me, something like that is a key issue about if I see an ICS working in silo about its own citizens, its own patients and digital access, we're going in the wrong direction. It goes back to what I was saying earlier about the fact that we need to tackle these things at place-based level and understand that our challenges are often challenges shared by others, public sector providers in our same patches.
Thank you. Thank you, Richard. That's fantastic. So again, a lot in that response. Before I bring in Sarah, I can just see, Ben, that you've got your hand up. If I just bring in Sarah to respond as a panel, and then if I can ask you to come in at that point, would that be okay? Right, fantastic. Sarah, I don't know if there's anything again on in terms of that, are we suitably robust as an ICS and recognising both the relationship points that Richard has brought in, as well as the points made by Geoff?
Yeah, and I can be brief because I think I mostly agree with everything Geoff and Richard really eloquently put. But I think just a couple points to reinforce, and some of this builds on what's already been put in the chat. But I think to answer your question broadly, yes, I do, even though I was a bit pessimistic at the start of where we've been and where we're going, I do think there is a noticeable difference in terms of kind of a buy-in to the vision and the understanding that the ICSs do represent a real opportunity to do something different, particularly around inequalities. And I think people have bought into that kind of moral responsibility, an economic one as well. So I think, and there's a changing perception, I work mostly with NHS stakeholders, but of their broader role that they have in communities and that they can't do this alone. So I think there's a lot of positive changes there. But then, what don't they have that they might need to really act on that? I think one thing that's been said that I think is really important is just getting that balance between central and local control right. Both Geoff and Richard had really eloquent examples of what to say about that. But I think, the reality is that there's a very top-down culture, at least in the NHS, that means the NHS is mostly accountable upwards rather than outwards. And though that is changing, and there's been some real intent, I think, on behalf of NHS England and others to kind of devolve more responsibility to ICSs, I think while we live in this culture where there's lots of performance management and assurance requirements, that will undercut the ability to really, for places to kind of take that longer term view and take risks and do what they need to do to deliver on some of these objectives. So I think lots of culture change needs to happen, not only within places, but getting that dynamic right between local and central decision makers. And I think talking a bit about kind of the relational things that are happening within places, I think as well, the NHS's acknowledgement, acceptance that it can't do this alone, and there are some things that it's best place to do, and others are better place to do, and that means also devolving responsibility within place and being a much better local partner. And being one thing, frustration we've heard or fear that we've heard within places as they're getting evolved is even though there's lip service being placed to say that health and social care and other local partners from the voluntary sector will have equal ownership and partnership in these places, there is a real risk and historical tendency that the NHS, given its relative size and scale, that they can lead to over medicalized solutions, or they can kind of crowd out the input of others. And I think we have seen really good examples of where that's not the case, and those local partnerships have flourished and they've been able to get that balance right. But I think there is a risk in the way that some of these structures are being set up, that those culture tendencies carry over, and we don't see a big difference there, because that's really the way that inequalities and some of these broader improvements on these broader determinants will really be made.
Thank you, Sarah. So actually your points there are less of a centralized control, more of that local control, and actually a word of warning, I suppose, in terms of how that power might play out in the future from a NHS control perspective. Okay, interesting. Thank you. Ben, can I bring you in, please, if you'd like to ask a question or point for discussion?
Thanks, Janet. Yeah, I'm Ben Anderson. I'm Director of Public Health in Rotherham, and I also sit on the South Yorkshire Integrated Care Board. And just to really say that those comments around devolution and the control over funding being localised really resonate, in terms of we're having really good conversations around our Integrated Care Board and at the Integrated Care Partnership with the wider sort of local authorities and voluntary sector, etc., around what we want to do on health inequalities, where we want to go with prevention. But it comes back to, at the board, responding to NHS England's template of questions that are activity, cancer waiting times, GP access, all of those things which are really, really important. And at the moment, all the funding that is coming down that we could do something with is predicated on very specific outcomes, very specific areas. So there is no way at the moment to get funding into doing the innovative, doing something different, testing approaches in communities, where we know actually we could start tackling waiting times by getting less people joining the back of the queue rather than more people through at the front of the queue. And it's that ability to be innovative locally, and I guess that trust and empowerment to local systems to make those changes that I just really, really want to see and embrace from that, in terms of give us the outcomes that we want to level up on, and give us the resources to make that difference locally. We're all passionate about doing it, and we all really want to make those changes, so it will happen. And it's that trust of local areas, knowing our communities, knowing how to work with them, and moving it on.
Fantastic. Thanks, Ben. So give me the freedom and let me get on with it. Pretty much. Okay. Hamish, can I bring you in, please?
Yeah. Thank you, Janet. I'd just like to echo what I've heard from Ben, from Geoff, from Sarah, from Richard. For me, it's about the perspective you take on the work, and within that, the kind of dynamic. And I think, I'm old enough to remember a whole variety. I put it in the chat box, the whole alphabet soup of where we've gone from primary care trusts all the way through now to ICSs and ICBs. But we're fiddling with structures, and the problem with that is you can pull a lever in the hope that it will change something, but it's not fixing the fundamentals. And the fundamentals really are that we should have localities, and I think they are natural, both at county and city regions within the existing fabric of how we divide healthcare, focusing on how do we understand and improve healthcare provision in the round, not just focusing on treatments, but thinking just as much about how we care for people as well as how we treat them, how we fix them, as opposed to being obsessed with activity, either improving activity in the case of elective care or trying to reduce it in urgent care systems. And that for me is about challenging the dynamic and the relationship between central government and local government. So I'd just like to echo that. I think what Geoff was talking about in terms of, we talk a lot about maturity, but actually we need to kind of practice what we preach and give people the earned autonomy, to use a phrase that was used years ago, in order to better understand and improve healthcare, generally from the perspective of the person or the people that need it when they need it.
Thank you, Hamish. And I think actually that was back to the point I'd say from Geoff as well, in terms of the two-way accountability, to NHSE, Department of Health, but also to your local democracy. Yeah, I completely agree. Okay, so Neil Wilson, you've got your hand up. Would you like to make a point? And then I'll come on to the other two questions if there are other ones after that.
Yeah, a lot of it I've put in the chat, Janet, but thanks for just bringing me in. Just in addition to what I've put in the chat, it's not just a cultural shift, that we need from the Department of Health as a centralising bureaucracy. Sorry, my phone's fallen. Don't get to sort of grovelling on the floor. Hopefully it won't go off. Secondly, it's about trust in local communities. And I just pick up the sentence that I thought I heard, I may have misheard, about that we've got health at the ICB. I think it was a point Geoff was making. Health at the ICB, local authority at place, and communities. I don't see that there's a false perspective. I've got the local hospital in my own ward, my political ward, and people think I'm in charge of that hospital. I don't see that communities versus local politicians, but I'm bound to say that after 30-something years on the council, are separate from community. And we are the representatives. So let's not get into that duplication. Our officers, are very clear. I think that the pandemic has taught us quite a lot, that we should trust our local populations to act with us as their representatives, our residents, to get to places where we don't necessarily. I think the COVID pandemic showed us that in terms of vaccination, but central government was still reluctant to trust public health. And we still haven't had a public health grant, which is symptomatic of some of that, I think. So it's just, there's a lot in there, I know, but it's about, there's not a false dichotomy, I hope, between communities and elected politicians. We are part of that. We live in the boroughs that we serve, or we should do,
Thank you.
In my party, we have to. Yeah. Okay.
Thanks, Neil. So there's a little, I think if I can just bring us on, it's almost, it's linked to.
Yeah.
Thanks. Thank you, Neil. I think this is linked probably. There's a few comments here around, Rotherham, Ben Anderson, you've said actually, let us get on with this agenda. We know how we want to move forward. Neil, you've said actually trust those local populations. What is it then in this third question? What outcomes and metrics should we be measuring to ensure that those efforts are met? How do we know that there's that you actually, there's a confidence or a level of trust nationally in those systems being able to deliver on those agendas? What is it? What's your experience? And we've heard obviously, you can't really measure relationships necessarily. We know that's a particular measure of success, but what if we were looking to move to give more of that autonomy, then actually what would be the outcomes and metrics that we should be measuring for success there, aside from clearly health outcomes? Shifting the dial on that. Has anyone got any thoughts on that final question?
Just before I come on to that, a few very quick responses to some of the really insightful conversation. I'd really like to Costa Wilson's point in the chat that we would have to trust local government more. We've all said, I think, that this is a place-based agenda, and local government is the leader of place, and therefore this should be an equal partnership between local government and the NHS, and local government bringing other product services, the voluntary sector with it. And I absolutely agree that the role of ward councillors, scrutiny, as well as executive political leadership, all have their role to play. And this is not a dichotomy between community activists and local politicians. This should be participative democracy, so it does come together. It's local government that brings that voice to local communities. So I absolutely agree with that. Just two quick reflections on other points. I remember being told probably 12, 13 years ago, this could never work because the basic systems of accountability through the NHS and local government were completely different. It was like putting oil on water. Well, we've demonstrated that you can have joint accountability between the NHS flown to Whitehall and Parliament and local government flown to the people through local democracy. It can work. I was also told very forcibly many, many years ago that this was all about culture and the cultural differences would make this impossible. I was told it's all about the colour of one's uniforms. When you come to get frontline staff, working with communities and joint teams, the colour of one's uniforms delineates where you are on the pecking order in terms of your status within the NHS and then between the NHS and social care. And I can tell you from personal experience, where this has worked after painstaking, effective leadership, those cultural differences disappear and you get teams of frontline staff really understanding each other, working as a single team across boundaries and making a massive difference to people's services and outcomes. And finally, in terms of the money, a small amount of the billions spent in the acute sector put into pump priming prototypes within the community would make a very big difference. And I don't think that, therefore, that is too big an ask. In terms of metrics, just to emphasise the point we've been making, this is about wider public services, not just NHS metrics. So we need less detailed NHS targets. We need more of a balanced scorecard. For example, access to parks per head of population in deprived neighbourhoods, levels of physical activity, and whether that's going up or down in deprived neighbourhoods compared to the average, levels of school exclusions, referrals to youth offending teams, and whether that's going up or down, access to health and care services. As somebody was saying before, look at the waiting lists from a BME perspective and from a deprivation perspective. What are those waiting times and why? So I think there's a wider range of metrics which I think should be in a balanced scorecard for each locality. Yes, there should be some standard national ones, but balanced with those local metrics which are appropriate to the place and their particular place-based agenda.
Fantastic. And Geoff, can I just ask, have you got that balanced scorecard in Bury, for example? Is that something that you've moved towards? Or?
Yeah, we have a local place plan for health and care. We cascade that down to neighbourhood level with plans around communities and people in those places. And yes, we look at those sort of measurements as well as the NHS standard measurements. I would say at the moment, I think we're still in circa 1998, 99 mode for NHS measurement. It needs to be a bit streamlined, and I'm sure that's possible. But we do try to balance that with a focus on community and the real metrics that matter to local people where they live.
Fantastic, thank you. Richard, can I bring you in on this particular question as well, please, in response?
Yeah, thanks, Jen, and I'll be very quick, very quick on this one. So just to echo, Geoff mentioned about trends over time being important. I'd say, perhaps more important than absolute measures. We want to see positive trends, but we have to recognise that step change improvement will take time. In terms of metrics, it's probably incumbent on me as an HSN chief executive to add this one. But if we ever do performance managed systems on transformation, which we rarely do, in my opinion, we often focus on what's been invented locally rather than what's been adopted locally. And I think it would be nice to think about metrics that force ICSs to demonstrate how they have stolen with pride from neighbours who have really got great evaluated interventions that need to happen everywhere.
Thanks, Richard. And actually, I think that's the purpose of what we're trying to get out of this inquiry session as well. And maybe that's a good way to sort of try and draw to a close. But actually, we absolutely are looking for those examples that we can steal with pride and share as recommendations back as part of this commission. So yeah, interested to hear from everyone that's attending in terms of what some of those examples might be. Okay, so I'm conscious I've really struggled to read, and maybe this is feedback for future sessions, but I've really struggled to read the chat at the same time as listening and intently to the conversation, the discussion that's happening. So really apologies for those of you that have put comments in. I'm happy to take a final point or question. I know, is it Kate that's been quite vocal on the chat as well? I don't know if there's any points you particularly want to make, but otherwise, yeah, please feel free to come in, or Christina. I don't know, Kate, would you like to say anything in terms of the points that you've made?
Yeah, it's been really interesting. We're slightly different in the Highlands because we integrated adult social care 3, 5, 7 or 8 years ago. So we're working a different model to, but I mean, the constraints and the urgency of what's facing us is the same across the patch. It doesn't matter whether you're in Inverness like me or anywhere else. We've got increasing numbers of older people. We need answers for what to do with those, and we can keep them in the community safe and happy for as long as possible. But there aren't enough care at home workers, and we're finding now that we can't staff the care homes because most of the people that worked there, and I'm sorry to bring politics into this, but I am a councillor, an SNP councillor as it happens. But many of our care home workers went back to Europe after Brexit. So, you know, we're sort of almost in a sort of perfect storm of needing more workers and increasing numbers of older people, but the private sector are not willing to take the risk anymore of not being able to make a profit for the shareholders. So, you know, it's a sort of unseen consequence of 60, well, it's more than 60, isn't it? Anyway, such a long effort by the NHS has kept everybody healthy until later in life. But then what do you do with all your 80 and 90-year-olds? And what do you do with, you know, the mental health list for 16 to 24-year-olds, which is excruciating with me. So I
think, yeah,
let's all try harder.
It's a common problem, I certainly think, that we're seeing as well, in terms of that domiciliary care out and care home provision. Yeah. So and thank you, Kate, for coming in and talking about what we will do. If you have put comments in the chat, we will go back through them, and if we need clarification, come back out to you and try and explore it more. Conscious I'm in the dying minutes now of our 2 hours, so thank you. It's been a fantastic session, and thank you particularly to our panellists for your informed summaries and also for responding back on some of the questions. I know we didn't get through all of them, so I may come back out to you and ask for the one of those questions that I don't think we got to talk about in too much detail, but I think there's a lot for us to go at there in terms of recommendations, and as I said, this is the first inquiry session. There are other ones that will follow, and we'll look to build those recommendations over the next 12 months is my understanding. So if things come to you after this session that you think would be helpful to share, then I please encourage you to do so. I think Siobhan has put the link already onto the chat. So yes, thank you again. I'll give you back a minute or so, but like I say, please come back to us if you think there's more things that you can add to this discussion. Really appreciate your contributions today.